How does cutting over 400 public sector science jobs across GNS Science, NIWA, Callaghan Innovation, and other government departments support his coalition commitment that, quote, decisions will be based on data and evidence, end quote?
At the moment, there is clear evidence Māori, Pacific, rural and low-income communities have been discriminated against by the health system.
Well, it's pretty simple. Race shouldn't play any part in surgical need and determining surgical need, and that's our position.
Today, ACT is proud to recognise the common humanity of each New Zealander by requiring that public services be delivered based on need, not race.
Racial discrimination, it's got to stop.
We've seen as recently as last week in Hawke's Bay, government departments using just one statistical indicator, a person's ethnic background, to decide how to allocate public services. This government is committed to a social investment model and sound use of data in all it does in order that we make sure the people who really have the greatest need are those that are getting the help.
I'm a public health physician, so a medical doctor that's specialised in public health medicine, which is the area of medicine that looks at the patterns of disease in populations. So zooming out and working out at a whole of population level, who's more at risk, who's less at risk, and how do we effectively prevent and treat diseases at a population level. So it's through that expertise that I've become involved in health inequities research and epidemiology about how diseases are distributed in society. Scientific researchers that are familiar with data in this area, that makes no scientific sense to us whatsoever. From all of our research, ethnicity is not just an evidence-based marker of health need, but consistent, overwhelming evidence tells us that ethnicity is a stronger marker of need than the other characteristics that we have at our disposal, like deprivation or age or rurality. So it would seem that it's completely contrary to showing a regard for evidence and science. It's important to note, I guess, that firstly, it's not the ethnicity itself that leads to poor health, right? It's because racism and marginalisation are so strongly distributed along ethnic lines in New Zealand, which makes ethnicity such a strong predictor of need. No matter where we look, we have evidence of lower Māori life expectancy, for example, higher health need, lower immunisation, lower access to health services, and poorer health outcomes. These are all evidence of ethnicity being a very strong marker of need. And for example, ethnicity is the strongest marker of avoidable death, even after adjusting for deprivation or rurality. And if we look at, for example, even those people living in high deprivation areas, Māori will have poorer outcomes than non-Māori, even in high deprivation areas. Wouldn't it be nice if Māori and Pākehā shared the same likelihood of living a long life in good health, or the equal chance of receiving a GP appointment or a lab test? But, you know, the evidence that we have is that this is currently not the case. So people are not turning up to health services with equal levels of need, and they're not being treated equally, and they're certainly not receiving equal outcomes based on ethnicity. The good outcomes and high level of high quality service that Pākehā receive isn't the same for other ethnic groups. So it's that inequity that needs to be continually adjusted. If we look at our babies, at 18 months, we've got 44% of Māori babies vaccinated compared to 70% plus of Pākehā. You know, Māori with type 2 diabetes are twice as likely to die than non-Māori. That's even after adjusting for all of the other things we can think of that might make a difference, like age or smoking or obesity or deprivation. We have overwhelming evidence that Māori receive less care, even just taking primary care, for example. Māori are 2/3 as likely to receive a GP appointment than non-Māori. So each year is about 750,000 missing GP appointments for Māori, even just to receive the same level of GP access that non-Māori have, you know, notwithstanding any of the higher health need that Māori might have. So if you think about what leads to us being healthy or not healthy, the determinants of health, those things are not evenly distributed based on ethnicity in New Zealand. For example, Māori are 3 or 4 times more likely to report experiences of interpersonal racism, racist treatment by a health professional, for example. We have evidence that Māori are much less likely consistently to report that their health professional listened to them or answered questions in a way that they could understand. And if our goal is to ensure that all people in our country have a chance at living a long, healthy life, and that we reduce the burden on our health system by identifying cancers and treating them early, then you want a bowel cancer screening program that works equally well for everybody, which is why we've ended up subsequently with an adjusted eligibility range for Māori and Pacific at age 50.